Good afternoon and welcome to the Rheumatology Nurse Practice Google Hangout. Today is a webinar produced by the Rheumatology Nurses Society, and I'm Kevin Lyons. I'm the Executive Director of the Rheumatology Nurses Society. Today we're going to be talking about the challenging cases in rheumatology, a focus on lupus, on SLE. And today our faculty is Jackie Fritz, our amazing nurse out in California, and Monica Ritchie, the resident guru of lupus, of all things nursing, not to elevate them too much. We also want to shout out a special thanks to GSK for the unrestricted educational grant that funded this series, along with some other activities. First off, to talk about Rheumatology Nurse Practice as an initiative, it's really a three-part initiative, and we're very excited about the activities with this. First off is the publication itself. This publication is available for free to anyone who signs up. So if you go to rnsnurse.org, that's our website, rnsnurse.org, and /RNP for Rheumatology Nurse Practice, or you can also look under the education tab there. You can sign up to receive this publication for free. We have multiple issues coming out. The one that you see on the screen, the visual of it, has been out for a couple of weeks. We have a next one coming out that's going to be discussing how is a lupus flare defined and how common are disease flares among patients with SLE and what triggers have been identified that may contribute to SLE flares. It's going to be a fantastic issue. It also has a very special insert in it. We actually have a full-size poster that's going to be included in there, and you'll see it in the envelope coming to your door. You can also access these activities or the publications online at the rnsnurse.org website. These are accredited activities. The RNS is an ANCC accredited provider of education, and most of our activities through the publications are accredited. We also would like to share with you about two other pieces of the Rheumatology Nurse Practice Initiative. One is what you're experiencing right now, and these are a series of live webinars, and these will continue. We have many more that are coming your way. You can also view all the archives of these webinars on our website, again, at rnsnurse.org. And then the third part of this is a dinner series. Many of you may have received a piece of mail sharing with you 10 cities. We're going to be in Sedona and Phoenix. We're going to be in San Francisco. We're going to be in Milwaukee. There's just a great list of cities, and we're coming to bring you a 2-hour free accredited education activity, and we're going to buy you dinner at Ruth Chris Steakhouse. So be sure to check out the website and take a look at that. Finally, I'd like to share with you before we get started, we have the second annual PJ Day for the Lupus Foundation of America coming up on May 2nd, 2018. So May 2nd is PJ Day. And if you go to lupus.org/PJ Day, you can find out some more information. You can also check out our Facebook page and any of our social channels, and you'll have more information. The quick story behind the event: PJ Day was inspired by one of Iris Zink's patients. Iris Zink is the immediate past president of the Rheumatology Nurses Society. Iris found that with many patients that have SLE, that her patient would struggle to fully explain how she was feeling about the extent of her exhaustion. She began referencing how many PJ days she was having per week to help Iris understand how she was feeling and use that as a way to determine the best treatment. That method caught on, and Iris began asking her other patients about their PJ days as well. We invite nurses and teachers, patients, friends, and family members to put on their PJ days on March 2nd and raise money for lupus research and increase awareness of lupus, and rally around the public support of those who suffer from this brutal impact. So join a team, form a team, share about the event. We're very excited about that. So without further delay, I want to jump into our session today. And Jackie and Monica, welcome. We love having you a part of this series, and let's get going.
So I think I'll start out. This is one of my more challenging patients. She's a 23-year-old female that was diagnosed with lupus at a very young age of 15 and was initially treated with hydroxychloroquine. She started in our office at age 19, and we met her in the ICU with high fevers, vasculitic lesions. She had severe alopecia, lots of pain, horrible fatigue, and that's how she came to our office. She was really, really, really sick. These were her labs. Her anti-nuclear antibody, or ANA, was high. Her anti-Smith was 6. Her anti-nuclear ribonucleoprotein was 8. and her Shogun antibodies was 8. And Monica and I were talking before that about double-stranded DNA, and hers wasn't positive, and her SSA and her SSB weren't positive. So Monica, you might want to.
So it's important to notice that the double-stranded DNA, although it's a big part of the lupus serology, either doesn't confirm the diagnosis. Some patients will have positive double-stranded DNA but not have the disease, and also doesn't take away the disease. The Smith, the anti-Smith, is 100% related to lupus. Or double-stranded, you can have some false negatives, particularly related to some virus diseases. So in this particular case, you can see that your patient, Jackie, has very high ANA. She had that beautiful Miller rash. I mean, that is classic. And she has a positive RNP. And it's important that we also remember that 4 out of 11 criteria is just for research. We don't use that in clinical practice. That patient with those particular serologies and those symptoms, 100% guarantees her the diagnosis of lupus.
So she's pretty sick. So in the next slide, we started her obviously on prednisone and mycophenolate mofetil, and it really controlled her disease for quite a while. And then when she started to fail the mycophenolate, obviously we had to add prednisone again. Remember, this is a young girl. So then we started her on belimumab, and my goodness, that was like an on-off switch for her. She felt so much better. And we tapered her prednisone down, and everything was doing swimmingly well. She started in culinary school, and then on top of being in culinary school, as if that wasn't enough challenge, she started working in her off hours, I don't know how many those are, for a catering service. She was stable on belimumab for 3 years, and hydroxychloroquine and prednisone low dose. And then just recently, she started showing up again with a malar rash and, not feeling well, and that fatigue day, or we call the pajama days. And she's, with, school and catering, she didn't really have a chance. So we've now switched her to sub-Q to see if that's better. She's only been on a couple months. We seem to be at a better place with her because I don't know what your experience is, but most of our patients on belimumab, they tell me they feel fabulous and the fatigue goes away and the symptoms go away. And then at about week 3, they start to not feel so hot again. And so I tell them sometimes that's to assure them that we know the drug is really working. And so switching them to sub-Q, we'll see how that works. But so far, we're just kind of at the baby stage. She's only been on it a couple of months.
I mean, this is a classical lupus patient, right? Because they go through those in and outs of different medications at a time. It's a disease that spans the lifetime, so you'll have to change it every couple of years or so.
Yeah.
What is your experience, Jackie, with belimumab and overall symptom improvement? And in my experience, it takes a while for the drug to kick in. It's not like prednisone, right? Or any other drug that works very quickly. It takes a couple of months, at least in my patient experience, for them to kick in. Even 4, sometimes 6 months mark is when they start to have some relief. What is your experience?
Well, most of my patients that respond, Monica, do pretty well. Usually between the 2nd and the 3rd dose, they come in and say, oh my gosh, I feel so much better. But then we don't sell them down the river and say, well, by tomorrow, your fatigue.
Right.
I obviously don't say that.
Right, yeah.
Explain how the drug works and that, we're hopeful that this will really turn their disease process. I tell them to keep a calendar of pajama days and fatigue and rash and kind of, watch and sometimes that helps them.
Yeah. I always tell my patients to keep a diary because it also helps them identify some triggers, right? Is it the sun? Is it their periods? But with the overall belimumab, it does helps to reduce the amount of flares, right? It doesn't completely, but I think that, as you said, after the loading dose, they start to see some improvement, but it's usually at the 6 months, 4 months mark that my patient's like, oh, I haven't flared in so many months, or I haven't flared in so many weeks. So I think the the good sign of the belimumab is that really, I mean, I had this patient who came in really horrible lupus on prednisone for at least 2 years, and I put her in belimumab, and she took almost 6 months after she became stable to have another flare. And, you know, she was doing very good. She was able to get work again, you know, so I think that belimumab has its place in the lupus, you know, as I say, it's not like, you know, it doesn't work right away, but I think that in terms of controlling their flares, it's been pretty impressive in my experience.
I agree. I think that with this patient, what brought her back, and she said to me, "Look at my face and hands, Jackie. Is it coming back? Because we've been 3 years without almost any flare." And I said to her, "Okay, let's go back and look at your schedule and your periods, and let's go back and look at all that." And it just seems that perhaps that's why we switched her to sub-Q, to see if it's going to make a difference in administering it weekly instead of monthly. So we're hopeful. She comes in this week. I'll stay tuned. I'll let you know. She wasn't wild about going with the sub-Q, but I explained that maybe by dosing her weekly that it would be better.
Yeah. I mean, I think there's all kinds of pros and cons, right? Pros and cons, they don't have to come in every month. Although I think a lot of the patients like to come in into the infusion unit, you know, and talk to the nurses and exchange ideas. But I guess for a lot of people who work, it's an easier thing. You know, you're home, you can do your own injection. And as you mentioned, you know, with the infusion, they may have that taper down kind of period close to the infusions where they start to feel like their disease is active. And we're hoping that, you know, with the sub-Q, that kind of goes away. I have a few patients on it, but they really literally started, so I'm not having that.
It's a little soon. Yeah, it just came out.
Exactly.
So, yeah, we'll see how that works. I'm just kind of looking into the future, and since I have the guru of lupus with me today.
I wish.
Well, we have a few more wrinkles. On top of catering school, on top of culinary school and catering, she happily announced on her rashy little discoid hand that, "Look, I'm engaged." And I'm like, oh, how lovely.
Hello, so, pregnancy.
Yeah. Oh, good. But how did you squeeze that in between everything you're doing? But so now the question is, what do I do with her as far as childbearing considerations, because she's so young? I mean, obviously, leflunomide, methotrexate, none of those.
Oh, yeah. No, those are out. So sept is going to be out of the window as well. I mean, I mean, you know, life happens while you plan it, and lupus patients love to, you know, throw you a curveball every once in a while, you know, particular with pregnancy. And it's good to remind us that they, you know, for a better successful pregnancy, it's important that the patient is like well controlled, or at least stable. And I'm not saying no flares, because that doesn't happen, but, you know, no active lupus nephritis, no organ disease per se before they get pregnant.
Well, we talked about that immediately when I said, "Oh, engaged, lovely. Are you planning to have babies? Please include us in your plans." So we can talk about what medications you can and cannot take. And so far, knock on wood, all her other labs, her renal function is good. Her acute phase reactants seem to be stable. So at this very minute, right now, we're okay.
And if you get back to her serology, she is Rho positive, and Rho positive is, you know, pretty much related to neonatal lupus, although only 2% of women will develop neonatal lupus. But it's important that she knows, because the OBGYN will be doing serial echoes, because it can cause some heart effects on the baby. So it's a scary kind of perspective for a mom to be in, you know that, you know, and even the rash, even if it doesn't affect the baby's heart, just that male rash and overall body rash on the baby is pretty scary. So we have to prepare our moms, you know, for that as well. In terms of medications, you know, so far, I mean, I have patients who got pregnant on belimumab, and they got reported and they got followed through, and thank God we didn't have any problems. But we don't have a lot to go on. You know, breastfeeding, we don't know. Do we stop it? Do we time it like we time with prednisone? Imuran will be a good probably addition if you need to. It's considered the old pregnancy category C, so it's still safe, but Cellcept is out, you know, cyclosporin I think is out as well. So we don't have many choices during pregnancy besides the good old prednisone, unfortunately.
Yeah, it's pretty scary, but I just encouraged her that, you know, if they were thinking about having a baby, that we really needed to sit down and discuss things with her and her husband, and, you know, get a high-risk OBGYN on board right away.
Always.
I already made some inquiries on her behalf with her insurance of who I would send her to. So I'm trying to be ahead of the 8 ball, Monica, because she's so young. I mean, most of our lupus patients are not this young, and I want to make sure we do everything right as best as we can for her.
Yeah, I mean, you can plan as much as you can, but lupus has a life of its own. And it's important that you kind of prepare for everything, particularly when they're pregnant, because then you're dealing with two lives, literally. So it's a pretty scary moment for lupus patients to be in, that, you know, risk of blood clotting. They usually have a shorter pregnancy. You know, placenta kind of, you know, stops working at 36, 37 weeks. You know, fetal growth retardation is another problem with that. So I don't mean to scare every mom out there, but you just have to we as clinicians need to be prepared for all of that, and be able to hold their hands, you know.
I'm there. I mean, the heterogeneity of lupus is just, it's a huge challenge. And, you know, I'll keep you informed, but we're hoping that the subcutaneous will work and that we don't have to add any other medications, biologics, or DMARDs, and hopefully we can just kind of swing along here. And I guess I'm assuming too much. She's just getting married. It didn't say she was going to have a baby.
Well, you know,
I was just trying to be ahead of it.
Listen, it can happen at the time, and I have patients who weren't even married. You know, they're engaged and they got pregnant. You know, the order is not always in that particular sequence, but it's just good that she's informed. And again, the high risk OB pregnancy always mandatory for lupus patients. They follow up very closely, and just have to be aware of medications. And, you know, if you do need to use prednisone during flares, particularly during pregnancy, gotta be aware of diabetes-induced pregnancy and other complications as well. So it's not for the, you know, faint of heart. It's you know, something that you lose sleep over it most of the time.
That's what we do, Monica, is we're there for our patients, and, you know, that's the purpose of these Google Hangouts, is to share our challenges with everybody. And I really appreciate your time helping me with this patient.
Oh, my pleasure.
Awesome. Well, that was a fantastic discussion, and we just are super excited about this next rheumatology nurse practice coming out. The poster is actually going to help you on this topic. We have a large poster on the current biologic therapies and current DMARD therapies in RA, and considerations for pregnancy. So, of course, you know, this is a RA edition coming out here soon, but still, is from a pregnancy standpoint, it talks about, you know, safe biologics and safe DMARDs, you know, through that process. Well, Jackie, you're a guru in your own right. I just have to qualify that. And we so appreciate you and Monica being on the broadcast today. Again, this broadcast is available for replay. So if you missed it, or if it was during your lunch hour, please come back and visit, share it with your friends. Part of the philosophy at Rheumatology Nurses Society is we make all of our education as accessible and as free as possible, so we can share with as many healthcare professionals as possible. So we thank you both. Monica and Jackie, do you have any closing thoughts for us?
No, I mean, lupus patients can be challenged, but it's amazingly rewarding to take care of them. I absolutely love the disease. I know, sounds weird, but I do.
I love rheumatology because we have the ability to treat the cause. And I think Monica hit the nail on the head when she said, yeah, we had Plaquenil for 70 years. So the fact that we have something new, for me, it's always another day of excitement when we have all these new choices to help our patients get through these, autoimmune diseases. So for me, that's really the special part of rheumatology.
Well, thank you both so very much. Another plug-in here is our annual conference is coming up in August. So again, you don't want to miss that. It's 4 days of just amazing education. Again, go to our website, rnsnurse.org. So thank you from the Rheumatology Nurses Society. Thank you again, Jackie and Monica. And we look forward to having you all visit us next time. Have a great day.
Thanks, Kevin.